Okay, it's going to be found in Title 9, Chapter 10, Article 8. That's the new and improved assisted living portion of the Arizona Code. And this one has to do specifically with quality management. Some of you have been dealing with quality management in one form or another for a while. Assisted living as itself has not had a quality management requirement up until now. So it has been generating a little bit of anxiety, and we're trying to get it across to you that it is not much different from what you've been doing. Other than that, you do need to document everything. And if there is one word to remember from today's presentation, that word is document. So R9-10-804, quality management. A manager shall ensure that, number one, a plan is established, documented, and implemented for an ongoing quality management program that, at a minimum, includes a method to identify, document, and evaluate incidents, a method to collect data to evaluate services provided to residents, including contracted services, a method to evaluate the data collected to identify a concern about the delivery of services related to resident care, a method to make changes or take action as a result of the identification of that concern about the delivery of services related to resident care, and E, the frequency of submitting a documented report required in subsection 3, which is coming up, to the governing authority. The term governing authority is defined in Article 1. And for the purposes of assisted living and probably for behavioral health too, that means the person who owns and or operates the facility that you're dealing with.
This next part of the rule.
You need the microphone.
I'm sorry. Oh, all right. Sorry. Thank you. The next part of the rule in 804.2 is regarding the reports that are required under the quality management plan. And so these reports have to be part of the plan, the policy and procedure that you create. So on number 2, you have to have a documented report submitted to the governing authority that includes an identification of each concern about the delivery of services related to resident care and any change made or action taken as a result of the identification of a concern about the delivery of services related to resident care. In other words, we want to make sure that the person who actually owns the facility, the licensee, knows what's going on in the facility. And one of the reasons is that we found in many cases when significant care concerns come up, it's because the manager and or the licensee are really not familiar with what's going on in the facility, and they're not aware of problems that come up. And then the report that's required in that subsection and the supporting documentation for that report are maintained for 12 months after the date the report is submitted to the governing authority. So the report itself has to be maintained for a year afterwards. Okay? Questions about that? And now we're going to go through, now that we've gone through the rule itself, we're going to go through a sample policy and procedure that covers these items. You're not required to use this policy and procedure, but you are welcome to if you want to. And remember, these rules are new to us as they are to you, so this is just an example of what such a policy and procedure may look like. And of course, we encourage all licensees to make their own policies and procedures fit their own facilities as much as they can. So, Zakia?
Yeah. Okay, so the next slide just talks about, it's R910-804. 1A, a method to identify, document, and evaluate incidents. And this is just an example. As Jim said, you don't have to use this, or you can take it and modify it. But we were just trying to come up with some examples. All employees must immediately make an oral or written report to the manager or the manager's designee of any condition, situation, or incident which has or has the potential to adversely affect the health and safety of one or more residents. So either you think it might happen or it actually will happen. You just want to come up with a way to get that information to the people who are going to do the documentation of that incident. And the next point, a manager or manager's designee shall document the condition, the situation, or incident on an incident reporting form. And we do have some sample forms at the end of this PowerPoint that you can use. You can take them, plagiarize them if you want. The manager or designee may delegate this documentation to one or more employees. So it's up to you guys to decide who you want to be filling out that form.
So, as an example, do we change that? You might put in your policy and procedure the following, or something very close to that. And whenever you see something in italics, that means that's something we're telling you about, but it is not part of the rule. So this slide is in italics, and it's a suggestion to you that you could use or you could adapt for your own use. So that you might say in your policy and procedure that within 48 hours, the manager or the designee shall evaluate the condition, situation, or incident to determine if actual harm has occurred or if there's a potential for actual harm. So this is pretty much what it says in the slide before, what you should do, and this is what your policy would say about how you would do it. And then another part that you could put in your policy and procedure was that the findings of the evaluation that you make will be documented on the incident report form or whatever else you want to use, or attached to the incident report form as appropriate. So you set up your own way of doing things.
Okay, so for 8041B, a method to collect data to evaluate services provided to residents, including contracted services, the policy and procedure might look like this. The manager or designee shall document monthly the number and type of incidents, patterns across residents, that is to say if several different residents have the same type of problem, like falls, for example. Which is the next example. Number of residents experiencing falls, number of residents experiencing weight loss, number of residents with decubitus ulcers, number of residents with possible healthcare associated infections, and that would be things like MRSA or C. diff, some of those that you've heard about in the news lately. Number of residents reporting the loss of personal property or clothing, and the number of errors in the documentation of medications, such as your medication administration records, treatments, activities of daily living, et cetera, that are provided to residents. Okay, again, these are not supposed to be all-inclusive. This is just to give you an idea and a starting point of where to start your own policy and procedure.
804C is a method to evaluate the data collected to identify a concern about the delivery of services related to resident care. And this is just an example. Maintain a line graph for each of the above to identify trends from month to month. And it doesn't have to be a line graph. It could be however you want to see the trend across time. You could do a line graph, a bar graph, a pie chart. You want to have monthly meetings between the licensee or the representative, the manager, any designees, service plan nurses, caregivers, and others as needed to discuss each month's findings and identify any trends. You don't have to do it by this time frame. It could be weekly, it could be quarterly. It's really up to you. Some of the larger facilities may want to do it more often to try to make sure the communication lines are going from all the folks who need that information. So, okay.
Okay, so going on with that, in the list that Jim mentioned to you with falls, infections, and that sort of thing, you want for any residents, specific residents, for whom concerns are identified, either individually or as part of a trend. So this is on 2 levels. The service plan for each of those residents must be reviewed and updated, if necessary, to reflect the services or actions or interventions that are needed to address those concerns. You're already doing this. This is what we already require. It's just that it's kind of put in a different way. Caregivers and others involved in providing services are notified of the changes to the service plan. So that goes to say that if a service plan is changed, different needs are identified, different services are added to the service plan to be given, that some mechanism must be in place so that all caregivers know that now this person does not go to the bathroom by themselves anymore, or that this person does need to be watched very closely so they don't choke.
Okay. And then, again, this is the same rule. For any trends that are identified as per the rule we discussed earlier, you need to have documentation of actions taken to address those identified trends. So, for example, if you have one particular resident who continues to fall, what are you doing for that resident? Or if you have several residents that have the same kind of problem, what are you doing for those residents? And the caregivers and others involved in providing services are notified of the actions taken and their specific roles in implementing these actions. In other words, we want to make sure that everybody that's responsible for taking care of these residents knows what their job is. And again, like Ellie said, this is what you should be doing already as part of your normal service plan updates. This is just something that is put in a different format in this particular rule in the policies and procedures. So.
The next part of the rule, 804E, it talks about the frequency of submitting a documented report to the governing authority. The report's generated as per 804, which has to do with collecting the data, and 804B, which has to do with collecting the data, and 804C, which has to do with evaluating the data. You want to have that submitted to the governing authority, and we consider the licensee the governing authority on a monthly basis. You can do it more often. It's really up to you. And if nothing happens during that time frame, then you want to also make sure you get that information documented and passed along to the governing authority as well.
The HIPAA concerns are everywhere. They are not part of this rule. They are not set aside in the new rules at all. But HIPAA concerns are everywhere all the time, and one of the reasons we're bringing them up is because of these reports that you will be making. Whenever a report containing resident information is generated, and that report is possibly going outside of the agency somehow, then you have to be careful of the HIPAA concerns. So you don't want anything in those reports that might be generated to identify a particular person or contain protected health information without safeguarding the confidentiality of those reports. So if you have put together a report that does not contain individual information, then that's what we call de-identified health information. Then you don't have to be quite so concerned about it. But remember, too, that if your facility only has had 3 certain incidents, or maybe only 1, you don't have to put a name to it. Everybody already knows who you're talking about. And sometimes they think they do anyway. So be very, very careful when you're generating these reports to not violate the HIPAA. Now, if you need a refresher on what is covered under HIPAA and what isn't, look at the link that's given there. It's hhs.gov, and it's the OCR/privacy/HIPAA Understanding Summary Index. What you have to do to get there, you go to hhs.gov, go to OCR, and follow the prompts until you get to HIPAA. You might have to back up once in a while. I did when I tried to check this out. Okay, so it does tell you what information is protected and how to protect the information that you have.
Okay, so now, as Zakia mentioned earlier, we do have in your handouts a couple of sample documents that you might want to use as templates for your own documents. There are 2 of them. There's an incident report and a monthly report. And although they are in the PowerPoint, so tiny that you can't read them, if you turn the page, there's a full-size copy, and it's printed on both sides so that you can see the 2 forms. So it's very tiny on this and hard to see. So it would be a sample, an example of an incident report form. So say a resident has a fall and gets injured, you would fill this out. Okay, so this is the report that we were talking about at the very beginning. You would include all of the identifiable information. Okay, so this report's going to have all of the very specific information about the resident that had the fall or had the incident. And so this is going to be a confidential document, like Ellie was talking about, that you would have to protect under the HIPAA laws and state law as well. So it would include, for example, in this form, you've got the date, time, location of incident, who was the resident involved, or were there more than one, any staff members who were involved or witnessed, a description of the incident, and you may have to have a second page for this depending on what happened. You might need more room. Was there an injury requiring a physician or hospital visit? If so, who did they go to? Did they go to their own doctor? Did they go to the hospital? Did they go to urgent care? A phone number, date and time that they transported. How did they go, by ambulance or cab, private vehicle? If there's a police involved, you'd want their information. And then the notifications there down at the bottom, which are currently required again anyway. In the current rules, that you have to notify the emergency contact name or the representative, the primary care physician, anyone else that might need to be notified, such as a case manager or another healthcare provider. For example, if it's a resident with more than one doctor, you might need to notify more than one physician for that. And then you would have the action that you took immediately to address the situation, the action to prevent any recurrence, and then the printed name and signature and date of the person who's filling out the report. And again, if you have to have more space for some of those items, like the actions that are taken, then you can add that as well. The second form is the monthly summary form. Again, this is just an example of what it might look like for your facility. It might look completely different. This is the one that has to be completed monthly by the manager or the designee and provided to the governing authority of the facility at least once a month. Okay? And you'll see that it says on their note, this form is not to be used for or to include any information which can be used to identify individuals. Okay, again, we're going back to the HIPAA concerns. So this form, which you're using to identify problems, you're not using this form to identify individual people. Okay? So, and again, these are just some suggestions for things that you might want to include. The number of type of incidents which did or had the potential to adversely affect the health and or safety of one or more residents. You know, for example, 4 falls, 3 medication errors, etc. So kind of an overview of all of the number of incidents that occurred over the month and the type of incidents that occurred over that month. And of course, we want that to be 0 as much as possible, but we understand that things happen, so we want to keep track of that. The next would be the number of errors in the documentation of medications, such as on the medication records, treatments, activities of daily living, etc., that are provided for residents. Okay, so these are documentation errors that we're talking about now. The next one would be the number of residents experiencing weight loss and amount. Okay, that's an important thing to be concerned about. Residents with decubitus ulcers, and we've broken it down into the 4 stages and unstageable. Number of residents with infections such as MRSA or C. diff. Okay. Incidents requiring the response of emergency services, such as the fire department, paramedics, or police. Okay. The number of residents reporting the loss of personal property or money. Any other incidents that you want to include, and then you would identify the type and the number of incidents just as you did above. And then down below we just have a small paragraph. Are there any patterns of these incidents either with multiple residents or a specific residence? If so, what are they? Okay, and we want to be doing this because we want to be catching those patterns you know, before they become a real problem, hopefully. Okay, and then again, at the bottom of the form, the printed name and signature and date of the person that has that form. So we had a question?
Yeah, I think the answer. Any thing that doesn't apply for that month, we still put zeros on there and submit the form.
Yeah, the question is if there are none, you still have to fill out the form every month? And the answer is yes. If you put 0 if there were no incidents. Okay. We have another.
How many don't have handouts?
Okay. We've got a couple of other questions. Let's see a show of hands first. How many people did not get a copy of the handouts? We'll make some more copies for everyone. 1, 2, 3, 4, 5. Okay. We'll print out.
Make sure to repeat the question.
Okay. Okay. We've got a couple of extras here that we'll hand out. Your question, ma'am?
Where it says incidents requiring the response of emergency services, fire department, paramedic, do you want just the number, or you want us to describe there was a fire in the kitchen or there was a break-in?
Okay. Well, for this is a summary report. So in this particular report, you would only have just like how many times the fire department had to come out to the facility. And on the previous report, which is the incident report form, you would have the specific information about those incidents. So if there was a fire in the kitchen, you know, you would have an incident report about that, and then you would also include that there was that one incident where the fire department had to come to the facility. Yes, ma'am.
This is obviously focused on assisted living. Are you guys planning on developing a sample specific to behavioral health that you would recommend us using?
We are not, but the Office of Behavioral Health might. Yes, I'm sure that they'll be doing a lot of technical assistance with their rules as well. Other questions? Concerns?
I want to mention this presentation will be up on the internet within the next couple of days with the forms for people to have access to use. So if you repeat that, please.
Yeah, we're going to have this information up on the internet for people to use and download, including the video that they're making now of the presentation. The PowerPoint itself and these sample documents will all be available for download. And just because I forgot to repeat the other question, it was whether or not we were going to be providing a similar program for behavioral health, a similar quality management plan. And the answer is that our office is not, but the Office of Behavioral Health is. We have another question, sir?
Yeah, is it July or October? This is on. I saw something that said July 1st, and then they said.
Yeah, we literally found out yesterday after we made all of these copies. Originally, the plan was that the rules would go into effect July 1st, so that's why your handouts say July 1st. But we just found out yesterday that legislation is going through that will. We still have to have the rules done and into the Secretary of State's office before July 1st, but they will go into effect on October 1st. Yeah, the question was about when. I'm sorry. I was just saying that the question that was asked was whether the new rules were going into effect in July or in October. Tucson, you had a question?
Yes.
Okay, go ahead.
Does the state need any submitted documentation from these new reports, or is this just submitted on a managerial level?
Okay, the question is whether the state needs these reports. The answer is basically yes and no. The reports need to be available for our surveyors when we come in, if we're doing complaint investigations or our surveys, to make sure that you're keeping these reports. But you don't have to actually submit these reports to us. The reports go to the governing authority.
Thank you.
Yes, ma'am. Okay, I'm sorry, just a second. Tucson, could you please mute your phone?
We have another question.
Oh, okay, just a second. We have another question here, too. So if you could just mute your phone for a minute, and then we'll get your question next, okay? Go ahead, miss. I'm sorry.
I think that earlier he was saying that I might have misunderstood, that they go into effect for behavioral health July 1 or assisted living is October 1, just to clarify.
Yes, at this point, everything is July 1. But as I said earlier, what is happening with the legislators working on the bill that we have over there, as well as the governor's budget, has some verbiage and words to look at extending the rule time frame from being implemented for long-term care as well as assisted living to October 1. The other departments in non-long-term care, medical, as well as behavioral health, as I understand it, is still going to be July 1. So,
with implementation October 1.
With implementation of October 1. And we'll be doing our survey work based on the rules that are in existence today.
Up until August 1st, October 1st.
Yes. So.
I'm sorry, that could
Yes, Kathy. Yes.
Okay, here's what we know. We realize that for the light switch to go off July 1, for the new rules that basically get submitted to the Secretary of State on June 28th, and we begin to survey July 1 with the new rule set, that the department determined that we would submit the rules July or June 28th. The rules would be effective July 1, but we will not implement them, survey to them, apply them until October 1, which gives the department as well as you all an opportunity for us to do some continued education, training, technical assistance before we begin to survey your facility to the new rules. So there will be basically a 4-month delay.
And when you say department, you mean ADHS or in all divisions underneath?
ADHS is and all divisions that are affected by these rules. Right now, everybody, all the rules that are proposed will go in June 28th. Okay.
Just to make sure I have it correct, sorry, we had some due
Okay.
at the beginning of July. If anytime between July and October, if we have some that are still by old standards and some that are new standards, we will not be dinged on things that are still under old standards.
That is correct. The survey compliance activity will be done based on the current rules you have for your class, as well as any complaints that come into the department would be investigated under the current class. October 1 is when the light switch goes off. That is right now for everybody. All licensing categories. So it would be assisted living, behavioral health, long-term care, and if you're under medical licensing. Okay. Yes.
Just to get a little more pedantic, I'm an outpatient behavioral health.
Yes.
It will be reviewed September 2nd week, just hypothetically.
Okay.
That means I will be reviewed under the rules and regulations as of today. But
Correct.
after that review, will be expected the next September to be of the new rules.
That is correct.
I have a question.
Yes.
The rules are going to be submitted the 28th. So the draft rules that we're seeing right now online are the rules that are going to be submitted, or are they going to be?
No.
Okay.
The rules that you're seeing right now online are moving target every single day. Okay? It's a moving target every single day. The general consensus is there. I mean, you're going to have the format that you see is going to be the same, but the guts, the content will change according to whatever there needs to be done for consistency across all the packages. So there will be, there could be wordsmithing, there could be a realignment of the way that they're formatted, tweaked based on the ongoing feedback that we're getting and the ongoing daily discussions that we're undergoing with this package. What gets posted on or about June 28th that will go to the Secretary of State will be the rules that will become effective October 1, based on everything we know today. Okay?
Thank you.
There's one more question.
Yes.
Did you answer that one from Tucson?
Whoa, what's the Tucson question?
We have a question from an assisted living provider about the quality management program. Yes, my question is, in a small facility like care homes, less than 10, do they consider it as an incident every time we call 911 for whatever reason?
Okay,
Let's say
so,
the patient says, oh, I'm sorry.
no, go ahead.
Let's say the patient just had a pneumonia and then suddenly she couldn't breathe. So you have to call 911. Will you consider that an incident report also?
Okay, the question was whether calling 911 for a resident would be considered an incident. And yes, it would. Anything that would adversely affect or has the potential to adversely affect the resident's health or safety would be considered an incident.
So whatever reason you call 911, it's considered an incident. I'm just repeating it just so I understand.
Yeah, and the question again was any time you call 911 would be considered an incident. Now, just to make sure that you understand that the opposite is not true, that just because you don't call 911 doesn't make something not an incident. Do you understand? So you might have an incident in which you don't have to call 911, but you still need to take care of something that's, that has the potential to affect somebody's health or safety. But anytime you do call 911, I would definitely say that would be considered an incident. Okay, another question here.
Go ahead.
In behavioral health, there's a lot of 911s that are not 911s, where paramedics show up, or police show up because of clients' delusions or whatever. They're not situations that are real. So we get those visits.
Could you repeat the question, please?
Yeah, as soon as it's done. Yeah.
And right now, they're not because they're not reportable to ODHL. But are they going to be in the future reportable because a paramedic showed up for not a valid reason, or 911 showed up because a call was made that staff are not aware of?
Okay. The question was geared more towards behavioral health clients. If somebody calls 911 for something that's not an emergency, and I presume you mean that the resident, him or herself, or someone called 911 without any real reason, would that be considered an incident? And that's something that would have to be taken on a case-by-case basis. But if there truly is no emergency, somebody just couldn't sleep, so they called 911, and suddenly the police and the paramedics are at your door, I would say that kind of a thing probably would not be considered an incident, but I would certainly look at each of those individually. And that might be something that you would also want to compile on your monthly report, though, to identify any trends, if there's a trend with that particular resident, that continues to use those resources, for example. Yeah, and that's the point that Ellie made, is that's for behavioral health, and we're talking more about assisted living, although we understand that a lot of assisted living facilities do have behavioral health clients. So, yes, sir.
You may have it down somewhere on here, but you mentioned that these forms will be available, print out on the internet. What is the website?
That's the website for the department. And we actually.
Won't be available to print without the word sample.
I'm sorry?
You said they're going to be available for printing soon.
Yeah, it'll be.
When will that be? Or now?
Well, they have to be approved, set up by the webmaster, and put on the internet. I'm not sure exactly how long that's going to take, but that'll be from the Office of Assisted Living Licensing's website.
As to what website you go to and when we can receive that.
Remind them, we don't want them to use these forms.
Well, yeah, that's.
I just want to remind you, these are sample forms. You are supposed to look at the forms and say, what fits my facility? Because some facilities are 10 beds, some are 5, some are 30, some are 120. So what fits the facility? We don't want you to just print these forms because, number one, there's no heading. There's no contact information. There's no, you need to set up your own form and maybe use these items as your guide to what you should be looking at. By the same token, we're not saying you need to do monthly reports. You do reports as often as it's prudent and expedient and necessary for you to do your reports. This is part of the...
We're told we have to do a monthly report.
But your behavioral health, right? Did behavioral health tell you that, or did you get that from our... Because our talking this afternoon, no. The rule does not say monthly.
The rule, yeah, that was in our sample. Sorry. Yeah, the question was about the monthly report. That was in our sample policy and procedure. As Zakia and Ellie mentioned earlier, the rule itself doesn't require that. We put that up as an example. You might want to. Yeah. Okay. So in Rule R910-804E, it says that the policy and procedure has to include the frequency of submitting a documented report required in subsection 2, which is that monthly report that we showed you, to the governing authority. So it was in our sample policy and procedure that we showed you that we said it had to be on a monthly basis, okay? But your facility is your facility, and you would do that however often. Like Ellie said, that for the smaller facilities it might need to be quarterly, or Zakiya said that for the larger facilities you might need to do it weekly, depending on how often incidents come up and what your particular facility's needs are.
So the inspector's not going to come around here for a 30-day thing and write us up because we don't have one.
They're going to do it according to your policy.
The question was whether they would be cited if they didn't have a monthly report, and the answer was that the surveyor will survey to whatever your policy and procedure is. So if your policy and procedure says that you need to do the monthly and you don't have them monthly, then yes, you would be cited. If it says quarterly and you have them quarterly, then we would not cite. Okay? That would be according to your own policy and procedure.
If every time you call 911, you have to do an incident report, and on the incident report it says that actions to prevent recurrence. And let's say someone is experiencing chest pains and you call 911, or let's say their blood pressure is dropping. It's a medical reason. It may not be something that we can prevent from happening again.
Yes, it's not necessary to use this report to fill out each incident, as we talked about earlier, with someone calling 911 and other kinds of situations, case by case. So again, depending on what your policy and procedure is, how you report different incidents, that's what it's going to tell us when we come out and do our survey to see if you're following your own policy procedures.
So you don't have to do it every time.
That's
you call
correct.
911.
You do not have to call 911 every time. Any comments that Kathy has to make?
No, my only comment is that many of you already manage, and many of you are already looking at those things which we consider quality management triggers, criteria, indicators, whatever you call them. And those are the types of things that you need to sit down in your own population and say, what is it that's most important for me to track and take action on? If I were to try to market my facility out there and they want to know things like, well, what's your medication errors? Well, what's your elopements? How many times does patient gets called 911? Those types of things that you do every day, those are the types of things you need to evaluate to put into your quality management plan. Things that you want to put in place to either demonstrate you're doing a good job or stretch yourself and use it for an opportunity to say, I could do a better job in this. I don't know what it is. You all know what those things are. My little piece is probably more related to financial. My family, at the end of every month, they know that by the 5th of the month, Mom does her budget. Anytime my food bill goes over $400 a month, we sit at my table and say, why did my food bill go over $400 this month? If it's below, we celebrate. If it's above, we ask why. That's what your quality management plan does. It helps you evaluate your facility. It gives you an opportunity to say, this is what we're doing well, and this is where we could make better improvements, or we could do better. So they gave an example here. It's purely an example. Each of you need to go back in your own area and say, what is most important for me to be able to demonstrate I'm doing a good job, or I have an opportunity to improve. That's your quality management system. I just described to you my quality management system in my home. It's not written down, but everybody knows by the 5th of the month, I'm going to be talking to them about my food bill. So, take that and apply it to how you're providing the care, how many complaints you're getting, maybe number of turnovers, how many people got transported to the emergency department, the number of people that may be having other issues or concerns. Those are the things you need to be tracking.
We want to thank everyone for coming today, and I want to thank Zakia, Ellie, and Jim for their really presentation, and Kathy McKinnon. She's the bureau chief for the medical side of the house, and that's over a couple thousand different kinds of facilities. And so, we all have a big job to do, and each one of you have the most important job, even more important than what we do each and every day. It's the really health and safety of the patients and residents that you care for and provide services for. So we understand you have a difficult job, and we're here to help you provide customer service, assistance, technical support, and we want you to call us if you have any questions at any time, and we'll really try to work with you. And when we're out there doing our survey work, we're part of the same team and part of the same family. And so we're all in it together, and we just want you to know we really appreciate everything you do each and every day. So thank you all for coming today.